Yeah, here we go. All right. So I was appointed actually in 2011 as a Deputy Director of Digital Healthcare. That's what it was called right back when I first started. I started as a consultant at the same time as taking up this role. And at the time, it was all about being a clinical lead for the system that we were developing at UHB. UHB was only the QE at that point, by the way. We had Selly Oak, which was kind of being absorbed into our estate. So we were more or less a single site. And we were building our own electronic healthcare record, which at the time was pretty extraordinary. There wasn't, there wasn't Cerner and Epic. There weren't big secondary care records to buy anyway. So we didn't do it because we thought we were better than everybody else. We just did it because there wasn't anything else on the market at the time, really. We then went through the national program for IT, and we wanted to just join in that. We were going to stop building our records, but we were also building a new hospital, and we built the new hospital on the basis that the National Programme for IT would deliver us an electronic healthcare record, and we wouldn't need storage for notes. We wouldn't need notes in outpatients and so on. So the hospital was designed on that basis, and then of course didn't come to fruition in time that there was going to be this national EPR. So we were a bit stuck. So we kind of very rapidly expanded what we'd got at the time. So and I sort of joined in just when we were really expanding up this healthcare record. So the reason for my appointment, and I only had a couple of 2 or 3 PAs in a week, was to just give that clinical leadership, collaborating with the programming teams, and being a bridge between them and the clinicians in the trust about what we wanted, what we needed, what the EPR was going to look like. So that's what I happily did for a bit. And the director of digital healthcare was effectively the medical director of the hospital at the time. And then actually the whole landscape started to change quite a lot, and the CCIO as a thing was invented. And it was invented by what's now called Digital Health, the journal. And the networks were started to be set up by that kind of private organisation. And for a while, we didn't really join in with that as a trust. But then it became obvious that people were joining in all over the place, and people were starting to appoint CCIOs. So that's what the role was called, CCIO, from about 2014. I might have those dates slightly wrong, and that was then my title. So as I say, the organisation has changed an awful lot as well during this time. So we only had the QE when I started, and then we merged with Heartland's Good Hope and Solihull hospitals to become the second largest trust in the whole country, second to Manchester. And Manchester has got a much more kind of devolved model than ours. So as a sort of working organisation of combined hospitals, is a very huge institution now. And then, of course, we had COVID, and the West and East Midlands had very high impact from COVID, as you know. We were the highest admitting hospitals across the whole of the country. We had the highest incidence across our patch, and that was really very impactful on all of the hospitals and, all of the staff. Not to mention the people who were, living in the Midlands at the time. Then, as you know, our hospital went through a very public fall of the trust executive. Effectively the whole of the executive resigned or were removed, and then the hospital, as a set of hospitals, underwent high surveillance from many overseeing organisations, including but not limited to the CQC and the Royal Colleges and all of the kind of other sort of subsidiary things. And there's been very, very high surveillance on all of the hospitals since. And then coming out of that sort of period of turmoil, we have now completely new leadership, and then the hospital then underwent complete reorganisation. So instead of a sort of model where there was group executive leadership for and one funnel, a lot of power has been devolved back down to the 4 sites, with a much smaller group executive overseeing the organisation. And that kind of those kind of reorganisations have very big implications for digital healthcare programmes, as you'll all be aware in your roles. But if you can imagine that, the leadership is changes very many times over a couple of years, you can imagine the disruption to the teams. Alongside of all this, of course, during the time that I've been in this post, there's been a massive change in the tech landscape too. So, I mean, the kids, people who've got kids will, have this conversation quite often where the kids are literally saying, "What do you mean you didn't have a mobile phone when you were my age, mum?" I've got a 17-year-old, a 15-year-old, and they just can't believe that the world operated like that. And neither can I, actually. I've completely forgotten that too. So when I think back to what we were doing when we really started to build PICS right at the beginning of this whole journey, it was really surprising to email somebody in Cornwall. That was an extraordinary thing. And we all take this totally for granted now. But actually, just reflecting on this and doing this talk for you, I mean, the changes that we've all seen, absorbed and kind of gone along with in the tech world have been absolutely legendary, as we know. We've had the rise of the big North American systems, and a bit like what's happened in the GP world, we've now got a duopathy in the in secondary care, secondary acute care, where we've got two systems, Cerner and Epic, who are dominating that market and are kind of locking down people into those two systems. And there's now quite a big national conversation about whether that's quite right, because the same thing, of course, happened in the GP world, and now there has been a bit of stagnation in innovation and so on. So that leads me on to my third point on this slide, because as a kind of digital healthcare outfit in UHB, with the resource that we had, which was high given the size of our organisation, we were really leading the pack in terms of NHS innovation, building a healthcare record and all the rest of it. Now we've kind of moved into being mid-pack. We're no longer kind of leaders in the field because of the rise of the other EPRs. But we do obviously have a huge amount of data because we've been doing it for such a long time. And I'll come back to the data later in the talk. And it's been an interesting kind of way of that we've been sort of involved in the national conversation, because we were the poster child for a while about, we were amazing and we'd done all this amazing innovation and we were showing off everywhere we went. And then it completely reversed. And we were told that local innovation was not acceptable anymore, that we should be partnering with private companies, that we shouldn't be doing local innovation. And in fact, as anybody who was doing local innovation will know, over the last 5 years, money was definitely sort of cut centrally. Not that we actually had any money originally, didn't make much difference to us, but definitely as the money flowed out centrally for the digital revolution, anybody who was doing local innovation was not allowed any of that money. And now actually it seems to be changing back again, and this kind of blended approach to local innovation, especially from within the NHS, about people who are doing it, kind of for the love of it, almost. I mean, definitely not for profit or anything like that, is again back on the picture again. And we might want to talk about that a little bit after the talk, because that sort of blended approach to partnering with industry partners, but also not squashing local innovation, I think is a kind of is something to be considered. So then, over the tenure that I've been here, what have we done? So in the hospitals, locally, ourselves, for CCIOs and CNIOs, I would really encourage. The biggest, most impactful thing most successful thing that I did was network and set up networks across lots of different places. I'll come back to this theme, you'll see, in all the different sections. But we set up local networks for doctors. So we've got a specialist in every specialty and on every site of our hospitals who are a member of the design groups for all of the digital systems. We've done the same thing for nurses, we've done the same thing for allied health professionals, and we've done the same thing for pharmacists. So we've got these 4 groups running. They meet monthly, apart from the allied health professional one, which I think is bi-monthly now, and the pharmacy one, which is weekly because we run our own drug dictionary. But this means that you instantly tap into a lot of very dedicated health professionals who will support and help you, but will also give you very sound advice all the way through, all of the time. We then set up a set of business analysts. This is because we soon noticed that I couldn't on my own go out and talk to every single clinical group or need that we were trying to set up projects with. So these business analysts are nurses who are either still nurses or have stopped doing their nursing but have backgrounds in wards, outpatients, theatres, all over the place. And they can go out and link with clinical teams to understand what the need is. And of course, they very deeply understand what's on offer in terms of our digital programmes. When I started, I didn't understand what project and programme managers really were or what they were for. Now I think they're totally crucial to the way projects and programmes run. We've got a programme manager running the whole of the PICS project, for example, and then project managers are sitting underneath him to run the projects. And project managers, as I'm sure I'm preaching to the converted on this call, but they keep projects going. They make sure things don't get dropped. They're very good at keeping people to time and understanding where the gaps are. We've made very solid links with our IT department. And we have regular meetings with our integration team, our document management team, our automated processing team. And we've recently put together an enterprise architecture team to try and have a look over all of the things that we're doing across the trust and link things together. We've got very strong links with informatics, of course, for all the data, and I'll talk about that later in the talk. And then we've set up, over my tenure, strong links with R&D. I'm interested in research anyway. I came from a kind of research base before I came into this job. So I was always very interested in whether what we were building and doing was working and whether there was any research or evidence for it. And of course, this whole field, because it's so new, is largely absent of data and evidence, and definitely within the NHS it's lacking. There's quite a lot of stuff, of course, from North America. They were slightly ahead of us with their R&D, but now we've got huge data sets within the NHS, and we can use them not only for understanding whether digital systems work and whether what we do, and I'll show you some of that kind of research at the end of the talk, but also now, of course, the data is so rich that it can be used for any sort of clinical research that we want. So the data generation is massive. So we've got now we've used this EPR across 3,000 beds, and we have 2 million outpatient appointments a year, and in all of those episodes we're now using EPR. So in 1 year, we report 67 million results. We do more than 3 million prescriptions, and we do more than 119 million recorded observations. So these are huge data sets now, and we often say in the hospital now, it's not lack of data that we're struggling with, it's the overwhelming amount of data that we've got and how we process that properly and really utilise it. By spreading the EPR out across all of our organisation, we increased our HIMSS IMRAM from stage 2 to 5. And as you all will know, that those last two stages of 6 and 7 keep on changing, but they're quite significantly difficult to obtain. But we do on our strategy we aim to reach stage 7 for across all of our organisation. Okay, so here's the clinical impacts of what happened. So this is studies of the rollout and what we did in the rollout and how we changed things. So in our organisation, you can see along the bottom, the red line is the QE. So this is the place where the EPR was already in. And what we did was we rolled out that EPR to our other sites. So Birmingham Heartlands Hospital is in purple, Good Hope Hospital is in green. As you can see there, this is just talking about background insulin. I'll show you some other metrics too. But we moved from a kind of funny system of bits and pieces. So we had JAC was a prescribing system. We had paper. We had some dendrite databases. So in some specialties, there was some stuff going on electronically, but wasn't joined up with each other. But what we've done here is put in a system where we can watch and see whether people are giving drugs when they should be on time. And you can see that as you do this, you can bring all of the hospitals into the same place. Now you say, well, now why is that? Because actually they did have an electronic system before, just wasn't actually being used to track and understand behaviour and change it. Now we haven't done a lot about changing the behaviour yet, and I'll show you the later graphs, but as you can see, just simply by putting it in and having a place where it's easy for people to do the right thing, all of a sudden, and knowing, by the way, that this data is going onto dashboards and the management will be looking, all of a sudden you start to see that missed insulin, which, as you know, is a critical drug, is coming down to a baseline. And as you can see by the QE's baseline, by the way, we did some work a long time ago to try and change the culture in missed doses of drugs, and that these cultures get embedded and then they get sustained. Here's the missed antibiotics one. So same thing, very variable across the other sites, and then just coming down, not quite to the baseline look, but coming down, and definitely a lot better than when we started out. There's, by the way, anybody's interested in that, we're going to try and publish all this stuff soon, but for the rollout, there are loads and loads of metrics like that. This is another thing that we did. We looked at how doctors behave when they're faced with VTE scoring. So VTE scoring, for I'm sure everybody on the call knows, but just for clarity, hospitals have to assess patients as they come into the hospital to see if they're at risk of clots. If you're at risk of clot in a hospital, you should be given prophylactic heparin to stop clotting unless it's contraindicated because there's a bleeding thing or something going wrong. So most patients in hospitals on pathways need to have prophylactic heparin to stop the sometimes fatal consequence of getting clots. And as you can see, at the top graph shows the behaviour of doctors at the start of the project. Each dot is a doctor. And if the doctors are doing what they're supposed to be doing and giving VTE prophylaxis, then all the dots will go down to the bottom of the graph, which by the end of the project you can see is what happened. So what we noticed was, although we had very high scores for VTE assessments being completed, the assessment suggests to the doctors that they might like to prescribe enoxaparin or not. But what was actually happening, as you can see in the top graph, is lots and lots of doctors didn't prescribe the enoxaparin that they were being suggested to prescribe for the assessment. So we went out to all the doctors and asked, not all of them, we went out to a set of doctors and asked them why this was happening. We went out to doctors who always prescribed this, right, and doctors who never prescribed it and asked them why. And the doctors who never prescribed it were generally not bad doctors, they were just cautious, and they sort of just left it for somebody else to do because they were a little bit scared of getting it wrong. And when we pointed out to them that, you know, this was probably quite dangerous behaviour, those individual doctors totally converted their behaviour. But what was really interesting in this project was all the other doctors converted their behaviour too. And you had this massive halo effect because they all start talking to each other and they all start saying, hey, you know what, they watch this and they know what you're doing and everything. And this is sustained now across the hospitals as well. So data generation use. So data can be used in direct care to enhance patient safety. So we can put things straight into the EPR to say nudges and alarms and alerts. And as I've shown you, if you then use those alarms and alerts and nudges and follow up your data and understand it, you can do projects that actually really change clinical behaviours. Then you can start to transform services. So in my opinion, it's incumbent upon us as the digital healthcare leaders that we should be accumulating these kind of evidences off the back of our EPRs and then doing vigorous research about what works and what doesn't work in an EPR. By the way, I'm also now interested in my latest project is to understand what alerts don't work so we can take them out, because alert fatigue is very real too. So it's all very well adding alert for every safety thing that goes wrong in your hospitals. But if you're not careful, what you do is you get so many alerts, then nobody reads the really important ones. So, you know, it's both about what does and doesn't work. And I'll go into some more papers a bit later to try and illustrate this a bit more. I think these kind of studies can then form the basis for NHS-wide clinical decision support rules. So if we prove in the NHS, in our own data sets, that things work, we should be spreading them out, and we should be rather like nice guidelines saying that these are mandatory within EPRs across the whole of the NHS. And they should form digital tool libraries. So in my opinion, CCIOs have a responsibility to ensure this evidence-based implementation of digital healthcare tools. Okay, so that's about the hospital. So what about across the region then? So we've done a lot of regional work actually, collaborating over many years. Now, Masood and I first got to know each other many years ago when we were trying to set up this project called Your Care Connected. Your Care Connected, the idea was that you could look, if you were in the hospital, you could look into the GP record. And Masood led this project by sheer force of energy, I think, because we ran into a lot of problems with information governance. GPs were scared about sharing data because at the time they would be personally liable for data breaches. I mean, GPs were in danger of losing their houses and things like that. So it was a very, very careful project done over a long time with lots of collaboration. And this idea of networks and collaboration, I think, is completely essential to the success of projects, which is why I'm so passionate about things like this network. That, of course, Your Care Connected has now morphed into the shared care record. And so this is now, not only can we see into GPs, but we can also, GPs can see our data, we can see each other's data across mental health and acute care, and we can share with ambulance services too. So this is a huge project that's really started to join data and makes a massive difference to what we can and can't see in terms of being blind to other bits of the patient pathway. And now Masood is going on to more work of the same nature, collaborating to join patient pathways up across our region. Now, this, of course, has been nirvana for some time. If you're a patient, what you want to be able to do is move around the healthcare system and have good care, good joined up care. You don't want to repeatedly have to have tests. You don't want to have to repeatedly tell your story. And you certainly don't want to have the inefficiencies that are going on at the moment. So the collaboration about workflows for clinicians is important, with patients centrally in it. GP Direct Action recently has started to disrupt some of these pathways again. It's quite interesting how we move as we go through time, about which part of the health system is stressed enough to be, going on strike or being upset. And as you know, at the moment, that's the GPs. But anyway, so the regional work again is all about networks, and I think Masood would also corroborate that actually, if you can get the right people in the room and you can get people to be persuaded that this is the right thing to do, you can really start to change how clinical care works collaboratively across the region. So in this way, so inside the hospital, we're joining up services. We're trying to make referral easier. We're trying to make onward referral easier. We're trying to put data at people's fingertips in terms of remote access. We are very interested in the UI of different systems. I think all of us now really understand this. Some systems are very easy to use and some really aren't. We are promoting all of this work that we've done inside the hospital about missed medications and changing clinician behaviour so that we can maybe utilise this beyond the walls of our institution. I think I've talked about shared care record, referral management, so communication and patient ownership. I think, those have come out of the previous points that I've said. So then nationally, so the HDR UK network has then spawned the CCIO network, and these collaborations mean that we can share all our ideas, and we're not all kind of repeating ourselves inside the walls of our institutions. We've also been trying to influence the national conversation. I've talked about the sort of research side of it. EPR in its own right, of course, we've had lots of conversations about how we can integrate this and how we can build either monolithic systems or integrated systems and go across all of these different services. So I haven't mentioned social care, but of course that's the big deal that we haven't cracked yet. Okay, so I'll just move on to some stuff about the published evidence then and the research and innovation. So this is just a selection of some of the work that we've done, just to try and demonstrate some of the points I've said about use of data. So we did a big study on, we built the EPR for ITU, and then we rolled it out into ITU, and we wanted to know about how that had impacted. And we studied. This is the paper, by the way. That's if you can have we can share these slides afterwards, and you can see these papers. But so we demonstrated that actually, not surprisingly, if you have paper charts in ITU, one of the biggest things is adding up numbers all day in columns, adding up how many drugs you've put into people, what kind of infusions you've given, urine output, so on and so on. And if you study the charts, the paper charts, there are lots and lots of mistakes in the paper charts. Now, probably not many of those mistakes are important, but in our institution, we were making between 6 and 14 data errors per day, which equates to 219,000 errors just in fluid balance in 1 year. So probably, even though the EPR isn't important in correcting many of those errors, even if only a very tiny proportion of them are clinically significant, you're going to catch quite a lot by just simply putting an EPR in. This also demonstrated a lot of time saving, because nurses in ITUs spend a long time repeating and copying charts or trying to find things from old charts. And if you've got a good user interface with good co-design, which I go on and on about in this paper, as you would imagine, you can save a lot of nurse time as well. And I think there's a lot of evidence out there to say the opposite, that digital systems can sometimes consume time, clinical time, but if you get your user interface right, they can really help. And I think that's quite a crucial point. In blood transfusion, so we have, nationally, we know that we waste this very precious resource. There's a lack of blood available, and then we don't use it very well when it's available in hospitals. We were over transfusing, according to NICE guidelines, a lot of red blood cells and platelets. So we put in this clinical decision support. These are nudges to try and change people's behaviour and ask them, do they really need the transfusions that they're now requesting. What we found in this paper was quite interesting. So overall in the hospital, across general wards and general medicine, where you get a lot of blood use, we did change behaviour and people stopped using as much blood. So there was a statistically significant reduction in blood use across the hospital. This wasn't the same in intensive care. In intensive care, the blood use fell slightly and then went back to where it was before. And it made absolutely no difference at all in haematology. Because I think haematologists are obviously already very aware of blood use anyway, and they're dealing with a very specific set of patients who've got very strange, need for blood, so you can't easily commute that from data inside an EPR. This study was important because when we saw that we weren't making any difference, there was no discernible difference in haematology, we removed the alerts so that we reduction of alert fatigue in haematology and the same in intensive care. So this study then informed us to do a further kind of update to the EPR to change it so that we knew that the alerts were in the right places and were impacting the right people. I've talked about the reduction in missed antibiotics in the recent study, which is not yet published from the rollout, but this is the old study on which it's based, where we put in these changes of behaviour. So the first stepwise change there, as you can see the lines coming down, is where we started exposing the data on our dashboards and people could see where antibiotics were missed and compare themselves to the next ward and so on. And then we put in a further step for investigation and talking to the teams where there were high levels of missed antibiotics. And that's where the cultural change came in. This was a long time ago now. You can see this is 2009, 2010. And that sustained reduction in missed antibiotics at the QE it's still the same. It's still that very low level, despite the fact that nationally we know that missed antibiotics in hospitals is much higher. So I think this whole idea about putting in changes and then over time seeing if you've actually managed to change the culture or not. And I'll be very interested now going forward to see what happens in our new in the hospitals that we've merged with, to see if we can do the same thing and sustain these changes. Because we've got the level of missed antibiotic doses down during the rollout, but whether they're sustained or not, of course, I can't tell you yet. Increased prescribing of anticoagulation. So this is the graph that I showed you earlier. So this is about not only putting in tools for assessment, but seeing if your assessment outputs are actually then followed up. In EPR, of course, we can't start prescribing. The EPR can't start prescribing drugs that are dangerous, like enoxaparin. It's not always sensible to give enoxaparin, so you can't have automatic prescriptions, but you can have proposed prescriptions, and then you can have projects that try and sort out behavioural change after you've put those in. So I'm a kidney doctor, so I was just quite interested in whether all these alerts and whatnot that we were putting into all EPRs across the place were making any difference to patients who were having acute kidney injury. And what we found is that actually I was quite cynical about these alerts. I didn't think that they would be making any difference, but I was wrong, actually. So these alerts across our hospital do demonstrably reduce patients worsening AKI. So people do read the alerts and stop all the drugs and start giving people fluid and start really concentrating. Actually, what also we saw after the alerts was an increase in ITU admissions and an increase in the number of patients having dialysis. So presumably because people were concentrating more. So positive impacts from these alerts, and more referral into renal as well. And then just to finally finish off the published evidence, I mean, most of the things that I've talked about above there are kind of doctory type stuff, and I collaborated with lots of doctors across different parts of the hospital. But we also have done quite a lot of work in collaborating with multidisciplinary teams. And this paper was published by a colleague of mine who is one of our senior dietitians. She was quite interested in whether dietitians themselves can join in with making outpatient lists of drugs accurate. Now, she's a dialysis dietitian, so she's quite interested in these very long lists of drugs that patients are supposedly taking, and whether they really are taking them, and whether talking to patients about what they're for and why they should be taking them, and so on. So we allow our trained MDT members to contribute to those outpatient lists. And she proved by looking at this over time that this hugely improves the accuracy of the prescription lists, and then can positively contribute in. And don't forget, of course, these are held across all of the different places the patient goes. So these very complex patients shared across cardiology and renal, and go and see the dietitian and go everywhere else. And everybody then can see this up-to-date list of drugs within our systems. Okay, I thought I'd just finish off with some kind of interesting new stuff that's going on in the hospital at the moment. So artificial intelligence is on its way in, and will change the face of medicine, no doubt, out of all recognition as well. So this is a skin analytics project. So this has been running for a long time in our trust, and the idea is that you go to a centre, you have a practitioner who can take a very standardised history, a very clever camera that can take a very accurate picture, and the two things then run an AI program to decide whether you've got skin cancer or not. This is a very interesting project to watch, because this was going to save the world and stop all our dermatology queues. But in fact, the AI has missed a couple of melanomas that were picked up by the doctors who are the second checkers in the system. And so we haven't been able to take out those second checkers yet, because the AI isn't safer than a doctor. It's not that doctors never miss them, of course, but you can't have an AI tool that misses them. The other thing about this skin analytics project has been the colour of people's skin. is so it doesn't work so well on darker skins, and that's obviously a very big red flag in terms of equality. So it'd be interesting to see where this goes to next. It's expensive, this project, and it's under ongoing evaluation, but it hasn't yet reaped any benefits in terms of savings for us. And the next one is chest x-rays, and anybody who works in acute trust will know that we do a lot of chest x-rays, and these queue all the time for radiologists to have to report. So this device analyzes chest x-rays, and it can tell you with high confidence if the chest x-ray is normal. It doesn't sound like very much, but actually that would remove huge numbers of chest x-rays from the queues of radiologists waiting for to be reported. So this is undergoing evaluation in our trust at the moment to see if we can utilise this in the clinic. So the next one is stroke thrombectomy. So if you get a clot in your brain, you have a scan, and the scan is looked at by a radiologist as quickly as possible to see if we can give you medicine to dissolve the clot. The AI solution provides much more rapid reading of these scans, and then can sort people out much more quickly to get them to the point where they can have these life-saving and disability-saving medications. And this is already in use in our hospital and is being used to speed that pathway up, which saves people's lives, but it also crucially reduces the amount of disability you're left with after a stroke if you can get to this treatment quickly. And then the final one that we're using already is in radiotherapy planning. So previously, laboriously, radiologists had to outline the area of a cancer that was going to have radiotherapy shined at it to kill it. And this took a very long time. And the AI tool just does this much more quickly and much more consistently. So there's not such variation in this contour planning. Okay, so on to the last slide then. So what's the future then? So the next CCIO coming in. So we are still developing the EHR. It's an almost complete EHR now. We've introduced pediatrics, just gone live with that. We're doing maternity just now, and then we're going to finish off our anaesthetic record, and then we'll have a complete EPR. And then, of course, you know, we constantly update it and change it on the basis of the feedback from our own clinicians. All the new patient pathways are coming in, Masood's work, so that's an ongoing big project. All this data research isn't ended. Of course, you can endlessly do all these things that I've been talking about, and anything, in my opinion, that we're putting into the EPR, we should be checking. AI-driven medicine will undoubtedly be the big new thing that comes now over the next decade. We are doing lots of research in our institution and feeding up into the HDR UK and the SDE. And we set up specific research pathways at UHB to allow easy data research with a trust-wide ethics so that anybody can come along and use our data sets safely.